double.
Hello.
Hello, Paul.
Hey, Peter, how are you? Good morning.
Morning.
Hey, guys. How's it going?
Good yourself.
Good, good. All right. Happy New Year.
Happy New Year to you.
All right. Give this a minute here. Okay, we'll give it a couple minutes. I think let's see if Dr. Welling's going to come on.
Yes, please.
Yeah. What are you guys up to today? You have clinic or cases or
Prof, it was yesterday we were in theater for a tough time, but today the autology team is not really in theater. Yesterday the airway team had a challenging case trying to put in a T-tube and replace a T-tube. The patient
Got
had
it.
some a false tract in the trachea, so cardiothoracics have joined the airway team today.
Oh, okay.
We did a tympanoplasty, a cartilage, butterfly cartilage graft with Louisa.
Okay. Got it. Okay. Okay.
Because Paris is on a short leave, so
Yeah. Okay. Great. Good morning, guys. Hi. All right. Okay. All right. Good morning, Brad.
Good morning.
How are you?
Good. How are you?
Good. Good.
Good. I'm
Uh,
I'm just getting into my office here, so I will
oh
mute
yeah,
for a
no
minute.
problem. Oh, that's no problem. So we're still going to continue finishing up some kind of case discussions that we started last week. I think when we can kind of open it up to everybody as we go through this. Just it's kind of good to talk through some of these types of things like scenarios that you're going to see. And we started a case last week. I'm not sure who else was there. I think maybe it was just Peter. But we were talking about a middle ear tumor that, for a patient that was presenting with conductive hearing loss, pulsatile tinnitus. And I will share the screen and we'll go back to that. Let's see. 1 second here.
While you're pulling that up, I should mention to the folks there that Dr. Basura's football team there won the national championship. Actually, both of his teams were playing in it, so he couldn't really lose. But congratulations to
Oh, thank you, Dr.
the folks of
Wellington.
the
I
U
didn't
of
want
M.
to, I didn't want to bring up that topic,
Yeah, I didn't want to bring it up either, but
I
unfortunately it's
know,
there,
I
so I got to
know. That's
deal with it.
why, yeah, I know it's probably tough to talk
Very
about.
difficult. I just about choke on the words.
End of an era, though. That's it. College football is forever changed now. I don't know. Well, I think Michigan was, it was, big enough win to force him into retirement. I don't know if you saw that, but there you go. All right. Let's see here. Okay. So what we're gonna do, guys, can you see the screen?
Okay. How do I see it?
Okay. Can you guys see that okay?
Yes, Prof. We are trying to close. Okay.
But you can't see it?
Yes, we can see it.
Okay, great. Okay, excellent. Okay. So yeah, so we're gonna probably for the next few weeks, we're gonna just try to talk about some cases. And I think it's important sometimes that to be able to articulate kind of what your thought process is about how you'd manage some of these things. And it's not designed. I know I've been in the seat before. You guys where you guys are sitting now. It's sometimes it's a little uncomfortable to be just being put on the spot, being asked questions after question after question. But there's value in that in terms of just being able to articulate what your thought process is about, what you're looking at and how you're going to manage it. And so look at it as that, from that side of it, not just like just being put, clearly in the spot. So Peter, I'm sorry. I don't hope I'm not making you feel uncomfortable by asking all these questions. Okay. I know in the States, when we do board examinations, there's an oral component to the boards or the qualifying examinations where they may show you a scenario and then they want you to tell you, they're asking you what you would do. So I'm not sure if you guys have that. I can't remember if that was the case. I know you have some written exams, but do you have an oral component too?
Yes, we do.
Yeah. Yeah. So this type of exercise is good for preparation for that, so it's always good to take that approach. Maybe if you're studying together, just throwing up slides on the screen and saying, okay, so patient presents with these symptoms, tell me about what you would do or what kind of questions would you ask, and then how would you work that up, and then okay, if it's a surgical problem, how are you going to manage it, that kind of thing. Okay. So last week we were talking about this finding of a middle-aged person who comes into the clinic with pulsatility and conductive hearing loss, and Peter was taking us through that. So Peter, you had described this finding well, and then you had obtained an audiogram, and maybe just for your colleagues there, you can reiterate kind of, what this audiogram shows and then what you did next, okay? Just to kind of pick back up.
Okay. So the right ear had a moderate to severe conduct and mixed hearing loss. And then the left ear was a normal hearing threshold.
And we did some tuning fork testing that suggested what did the tuning forks show, did you think, based on that? Or we did tuning forks?
The relay was air conduction, bone conduction was better than air conduction on the right ear, and left ear was air conduction better than bone conduction. But the Weber it was lateralized to the right ear.
Yeah, that's good. Great. And so your next step was to obtain a CT scan, right? And so again, maybe walk us through this CT for your colleagues, and then we could talk through what's next.
Okay, so an axial scan of the right ear temporal bone, and it showed a well aerated and well pneumatized mastoid. The external canal looked normal, and then there's a soft tissue density in the middle ear, specifically in the mesotympanum over the promontory. And we said it was in the region of the round window, which so that was it. There wasn't any other lesion we found in the middle tympanic cavity. And then also we made mention of the fact that this looks like a non-contrasted CT scan because the jugular bulb and the sigmoid sign, the jugular bulb, which is labeled as B, and the sigmoid sinus on the lateral aspect of it, and didn't seem to be hyper intense compared to the rest of the brain tissue. So we said it was likely to be a non-contrasted CT scan.
Yeah, got it. Yeah. So where we left this off last time was, so now you put it all together, right? What do you suppose is your diagnosis, and then how do you get to counsel this patient? Excuse me.
Sorry. Well, so we thought that I thought that it must be a Glomus tympanicum lesion or Glomus tumor, just restricted to the middle ear. So in terms of counseling, there are options to the treatment. We can choose to just follow the lesion, observe the lesion over time, and see whether it grows any bigger than it is. Mostly it's said to be less than 1 centimeter. That's when you would watch it. But so that's an option. And then the other options are surgical management and radiotherapy. For this, because it's restricted to the tympanic cavity, if we have to go surgical, we are likely to use the transcanal approach. But observation over time is also an option we can choose to start with.
Okay. So if you went transcanal, can you describe to me sort of how you would, I mean, procedurally, how would you make those cuts? What would you do? Or can you vocalize how you would approach the middle ear?
We can use Well, so you raise a tympanomiatal flap and enter the middle ear, and
When you enter the middle ear, where do you enter it? Do you enter it up high, superiorly? Do you enter it inferiorly? Do you enter it somewhere in the middle?
okay,
Can you describe, as you're doing this just a little bit, just to give us some insight into the rationale for the approach?
you enter posteriorly and inferiorly. Hopefully, yeah, so posteriorly and inferiorly, because even though as you enter posteriorly, if you go superiorly, you are likely to touch the ossicle. So you rather would stay more inferiorly. Just being careful that, anyway, on this scan, we don't have a dehiscent jugular bulb. So hopefully we shouldn't encounter too many, and we don't see an aberrant carotid artery too. So hopefully, I don't know, maybe if we had more scans, we could tell whether the carotid was in the normal position. But in any case, if you go more inferiorly, you are likely to avoid damaging the ossicles, and then you can visualize the lesion and decide on how you excise it. I read that you could do an arterial embolization before you attempt a glomus tumor surgery. But in this case, because it looks small, I don't know whether we can do without it. But I'm sure you might need to have your cautery ready and all your if you have to have I don't want to say, I was going to say adrenaline, but that might shoot it up, your blood pressure might go up because it's a glomus tumor. But in any case, you enter and then you approach it slowly and see whether you can take off the whole issue.
Yeah. Where's usually the blood supply for these tumors? So this is a small glomus tympanicum. So, they're very vascular, right? Assuming that's the pathology. As you lift your flap in your right, you enter inferior, right? And once you encounter this, do you know where the blood supply typically for these comes from? And have you seen these before, or how would you manage that?
The blood supply to the middle ear.
Or to the tumor, itself. Yeah. Where does that blood supply usually come from? And can you tell me how you might manage hemostasis in the middle ear? Because these are pretty bloody tumors. So can you talk me through what do you use to control bleeding or to get hemostasis on this little thing?
So the blood supply is from the inferior tympanic, usually the inferior tympanic branch of the ascending pharyngeal artery. That's what we read in the textbooks in terms of blood supply, in terms of hemostasis.
In terms of hemostasis, they've described pre-op embolization as a means of controlling intra-op blood loss.
Okay. Would you embolize a tumor this small? Would you, I guess we should back up. What are the risks of embolizing? Sometimes we use embolization, right? They use coils or beads or different types of materials to basically almost like create a stroke, right? You're cutting off the blood supply to the tumor with the idea that you're going to decrease its blood supply. What's the risk of doing that? What's the risk of embolization? Is that a risk-free type of procedure? And if not, what are those risks?
Well, I think, like you mentioned, you can cause a stroke, but if you are sure you have collaterals which are supplying the brain, then you may get away with it. But I think it's a possibility. So and even causing a thrombus formation and all that. So I think it comes with its own risks to some extent.
So,
So any other ideas? So what specific risk to, you mentioned, yeah, sure, strokes. What other things can happen that are not as, I mean, they're still devastating, but they're not like stroke-like. But have you guys ever seen somebody that's had been embolized and had a side effect at all?
The catecholamines, you can have a hypertensive crisis of a sort.
You certainly can. That's more under that, and that certainly can happen under anesthesia. Absolutely, right? You're absolutely right. So what do you have to do to, and that brings up a whole nother level. Do these tumors, do these typically secrete catecholamines, glomus tympanicums? Are they usually secretors?
No, most of them are not.
Right. How would you test for that? How would you test to see if someone was a secretor? What kind of labs would you send off?
Urine metanephrines.
Okay. Is there another option? Is it only urine? And for how long?
So 24-hour urine collection.
Okay. You can do a 24-hour collection of urine. Is there any other method that people use?
Serum measure.
Oh, sorry,
Yeah. EMA.
It may not be readily available throughout the world, certainly. But if you look at the latest literature, it would suggest that instead of sending what's supplanted a lot of urine collections is just serum metanephrines. You can actually send off a blood test, a serum metanephrine. And if that's positive, then you'd have to look at, is it this tumor or is there another satellite lesion somewhere else? So if this person had incidentally finding metanephrines from a tumor like this, would you suspect that it's from this tumor or could it be from something else?
something else.
Probably got multifocal disease.
Right. Exactly right. So then how would you look for that? Is there anything you would do for that?
So then you'd consider a nuclear medicine scan, like scintigraphy, I think it is, where you can look for I guess it's a whole body scan looking for multiple foci.
Mm-hmm.
I think there's other nuclear medicine scans that can be done. I'm not sure exactly which one it is.
You're right. There's certain scans that have uptake. So they're called dotatate scans. And these are highly sophisticated scans that are designed to show with radioactive tracers or markers that will pick up these tumors. If you don't have that available to you, what other things could you do? What other images could you obtain to look for a satellite lesion?
And geography, maybe?
Maybe not that much dedicated. What do you have here? What are you guys looking at right here?
CT.
A CT, right? You could get a CT, chest, abdomen, pelvis, right? And you're looking for any abnormal lesions. Where specifically are you looking? What are other areas where neuroendocrine tumors may arise? What are some other common locations in the body where you might see a neuroendocrine based tumor?
In the jugular valve.
Then the abdomen
And in
the adrenals.
In the adrenal glands.
The adrenals, right? So what's that called if it's one in the adrenal gland versus one that's say in the neck? They're similar in terms of histology, but what are they? Do they have different names?
Isn't there a pheochromocytoma?
Yeah, you get pheochromocytomas. Those are typically located near the adrenal glands, correct? So you'd be looking at the adrenals ectopically in and around the kidney, in the abdomen, as you mentioned in the neck, glomus vagalis, glomus jugularis, carotid body tumors, right?
Yeah.
Exactly right. So those are things you'd be looking for. And someone who's a secreting tumor. And what you look for that is either serum metnephrines or, like I said, the lab tests may not be available in certain areas. Obviously, it depends on where you are in the world. But traditionally, before that, it was usually a 24-hour urine collection, and you're looking for excreted metnephrines. But what if the normetnephrines are elevated? What if someone comes in and then you don't get the metnephrines, but the normetnephrines are way high? Have you guys seen that? Would that suggest that they have a secreting tumor, or what are your thoughts on that? Or is that a different interpretation? You guys probably-
More adrenaline. I think it's the same.
Yeah.
It's either metnephrines or no. It can be either.
I hear you.
I think it can be either. So I think it's still be thinking about this.
Yeah, so norepinephrines aren't as accurate. They're not, the sensitivity specificity is not as accurate because there's a lot of false positivity with norepinephrines. There are certain things in diets that can actually cause false positives. So that one you have to think about with a little bit more of a suspicious eye. If they have an elevated norepinephrine, it can be a false positive because there's a lot of things that can elevate that, and certain things in diet, caffeine, certain foodstuffs can cause this. So you have to think about that. So the gold standard is really the metnephrine. So you have to look at that closely. Okay. So getting back to the embolization idea, embolization is it's great. Some people think for larger tumors that are going to require bigger resections, and you're absolutely right. Typically, the blood supply to those larger skull base is usually the ascending pharyngeal artery, right? And that's a branch of the internal carotid, right?
That's right.
Yeah.
Excellent.
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 You're staying awake with me. Okay, good. Very nice. Yeah. What are the extracranial branches of the internal carotid artery? What are the extracranial branches of the internal carotid artery? Huh?
That's
That's okay.
that's very small. It's different. It's the carotid.
Careful, he's trying to trick you.
Shh. There aren't any, guys, right? There aren't any extracranial branches of the internal carotid artery, right? Where are the external branches of the carotid coming from? Extracranial branches of the carotid artery coming from?
External carotid.
The external carotid. There you go, right? And so one of those main ones is the ascending pharyngeal, right? That's one of the main ones that comes for glomus. Now, here, this is usually coming from the promontory, small vessels right on the promontory of the near the cochlea, right? So this is a small arterial branch, right? So you would never embolize this one. That would not be good because the risks would outweigh the benefits, and it's not really going to help you. But the key on embolization is if you're going to do that for larger tumors, is you got to do a really good head and neck exam prior to it, because there's a high risk of cranial nerve neuropathy, right? You can pick off cranial nerves. You can specifically down there low near the jugular foramen, depends on what the vascular aberrancy might be. Sometimes they may wind up occluding or embolizing a vessel that causes an associated cranial nerve neuropathy. You can have lower cranial nerve dysfunction, facial nerve, and then not to mention, if it winds up becoming ectopic, they can create a cerebrovascular event. So you have to be very careful with this. So embolization is not just a trivial type of procedure, right? Okay, so Peter, as you're lifting the flap, these are quite bloody, right? So you have to be careful in here. So you can, many times people will kind of scrape these off the promontory, and then there's usually a small pedicle vessel that you would cauterize, usually with a bipolar. Or sometimes if it's brisk bleeding and you're concerned about that, you can use, do you have any what kind of topical hemostatic agents could you put on a bleeder in the middle ear that's at your disposal? Is there anything you use to stop bleeding in the OR that's not cautery? other than your thumb?
Adrenaline.
Adrenaline, right? Yeah. What's the concentration of that usually?
1:1,000.
200,000. 200.
1 to 1,000. Yeah. Can you think of any dangers of having 1 to 1,000 epinephrine or adrenaline sitting on the surgical Mayo stand there? What kinds of things do you need to alert the staff about? If you have adrenaline 1 to 1,000 sitting on the Mayo stand and you might use it, what do you need to tell the staff and people about it?
You mustn't be giving it to the blood vessels directly.
No.
I'm sorry, I couldn't hear you. Can you speak up?
Mustn't be giving it to blood vessels, I guess, because you don't want
You
that.
don't want to inject it into a vessel.
You don't want to inject it into a vessel. Why don't you want to inject that into a vessel?
You can cause a cardiac arrest.
Yeah, absolutely. Oh my goodness. Absolutely. Right. So if you have 1 to 1,000 open in the field, you tell them do not pull that up into any sort of injectable device, right? That cannot be pulled up. That needs to be in a cup with just gel foam or cotton pledgets or whatnot, right? You never want to inadvertently pull that into a syringe and then that gets mistaken and then you inject that into the patient, because that'll almost guarantee a myocardial infarction, right? With that concentration of epinephrine. But believe it or not, that's happened even at my institution. That happened to one of my facial plastics colleagues, and they injected it and the patient had so that's highly, highly dangerous. So if you ever use that, be absolutely 100% clear that everybody knows that in the room. Yeah. Brad, were you about to say something?
I was going to say that in our institution, you have to label it on the table too. Even if you've taken it out of the original container, put it into something else, you need to label it. If it doesn't go directly from the packaged labeled device into the patient, you need to label it on the table just to remind people that it's
Mhm. Absolutely. What's more of the acceptable injectable ratio? You said 1 to 1,000 or one. Well, what's more of an acceptable injectable?
Well, I know 1 in 200,000.
Mm-hmm. Yeah, 1 to 200, 1 to 100,000, 1 to 200,000, right? That's often mixed in with lidocaine, right? They'll often say lidocaine with 1 to 100,000 or 1 to 200,000 of epinephrine, right? Okay, got it. I know it seems trivial stuff, but one day you guys will be, in that position potentially, right? Other than adrenaline, is there anything else you can use?
I just say one thing about that before we go on. I
Yeah.
actually do use 1 to 10,000 to inject an
Yeah.
ear canal in limited amounts. I don't use it in children. I use 1 to 50,000 in children, but I find that the degree of vasoconstriction is not necessarily any different than 1 to 100,000, but
Yeah.
the length of vasoconstriction is longer. It lasts
Is
a little
longer.
bit longer with a higher concentration. So if you're careful and they don't have any cardiac predisposing
Hmm.
issues, I will inject a higher concentration. I never inject 1 to 1,000.
Yeah.
So-
Yeah. Good. That's good. Yeah. Nice. Yeah. I don't think I've ever injected anything more concentrated than 1 to 100. Yeah. Yeah. Is there, so what else? I'm sorry, guys. Is there anything else what else could you use other than adrenaline?
You can use oxymetazoline.
Mm-hmm. Okay. Oh, yeah. It's almost like Afrin or some kind of a powerful vasoconstrictor you might use in the nose, right? Mm-hmm. Exactly. Yeah. You could put that on a little pledget. What else is an available powerful vasoconstrictor? We wouldn't necessarily use it in the ear. In larger doses and higher quantities, it's illegal. I'll say that.
Okay.
Cocaine, right? Yeah, it's I mean, that's a very powerful vasoconstrictor, right? People used to use that pretty readily in the nose, not recreationally. I mean, surgically, right? Where it's a powerful vasoconstrictor, right? Yeah. Here, have you guys heard of thrombin?
Something, yes.
Thrombin pledgets, those can often be used as well. That's a good hemostatic as well. Yeah, so thrombin, adrenaline, those are good things. So there's different ways to manage the blood supply here. You can either, if it's a pretty brisk bleeder and isolated, and you have a small enough bipolar, you can bipolar that, or you can put a topical pledget on there. Brad, any thoughts on your experience with glomus tympanicums?
I think those are all good points. I'd say if you happen to get into a larger vessel, then you might need something that could actually exert pressure as well as topical vasoconstriction or clot forming. So you might need a Surgicel or something called Nunit, which is like Surgicel. It's a little more dense, and you can actually put pressure against it and hold pressure until you get control of the bleeding. But for glomus tympanicums, that's usually not necessary.
Yeah. Yeah. So you finish the case, and then so when you put the flaps back, right? You're putting your typical metal flap back, right? You need to spend a little extra time doing that and make sure that that lines back up. Why is that so important? What can happen if you're not really careful about how you lay your flaps back down?
You can get a canal meatus stenosis.
But maybe not so much stenosis, maybe. But what other things can happen if you don't line those edges up well over time? Not maybe immediately. Over time, what might happen?
Retraction.
What if I told you this patient comes back to you? Okay, so you close her up and everything's great. She said, "Oh my gosh, my hearing's better. I got that pulsatility. My heartbeat is no longer in my ear. The audiogram is normalized. Everything looks great." And then she comes back to you, lost a follow-up, maybe like, I don't know, 18 months later with a draining ear.
Oh, canal.
And you look in her ear and you're like, wait a minute, what's this? I see some kind of soft tissue. I see it like a mass right adjacent to where I made my incision. And it's kind of looks like there's some infection in there, some soft tissue in it. What do you think has happened, or what could be going on there?
Canal cholesteatoma.
Yeah, exactly. Right. So that's one thing you have to think about whenever you're raising flaps in the ear, is you've got to be careful that you're laying those flaps back down correctly, and you're not overlapping skin, right? Where you're trapping skin under skin, right? And same thing. And have you guys done some canaloplasties a little bit probably in the bone lab, but also in the OR with Tashneem?
Yes, Prof.
It's really important. The tympanomeatal, excuse me, the tympanomastoid and the tympanosquamous suture lines, right? Those are suture lines within the tympanic ring. And when you're lifting those flaps up, sometimes you have to be careful. If you tear a little skin away, and you put something back down over that, you can trap skin there too. So it's kind of important sometimes to smooth those down, right? And make sure you're not trapping skin in those bony sort of jagged areas. Another thing that I think a lot about, and I always alert the staff, is if you're ever working in the middle ear, in and out of the middle ear, and someone's passing you things, you have to be careful of touching gel foam or wet things to skin. You can actually pull skin right into the middle ear. So there's always little things you have to be thinking about, that you could create an iatrogenic or a man-made cholesteatoma, right? So it just commands a lot of precision and thoughtfulness about how you manage these flaps when you're going out of the case. Okay. All right. Brad, any other thoughts on this case? Any other pearls?
Just maybe distinguishing between a transcanal approach and an extended facial recess approach. When do you decide to do one or the other?
That's a good question.
Or do you ever take a canal wall down for one of these?
Yeah. Peter, what do you think?
Yes, Prof. So I read that if the lesion is confined to the promontory or just the middle ear, then you can choose to do the transcanal approach. But if it's extending into the mastoid, then you do a mastoidectomy and do an extended facial recess approach to excise the lesion.
I would refine that just a little bit and say, in general, if you can look through the ear canal and see the periphery of the lesion, or on CT see that it's very localized like this, so that you could get around it just going through the canal, that you could do it transcanal, lift up the drum, go in and take it out. But if you can't see the extent of it, if it goes down into the hypotympanum, or if it extends up superiorly where you can't see the extent of it, then doing a mastoidectomy with an extended facial recess gives better access to the whole tumor, and having access to the whole tumor is important. If it's really extensive, then maybe taking the canal wall down is a reasonable thing. Although I'd say about 75% of the time we just do an extended facial recess, and maybe 10 to 15% of the time transcanal. It's quite small, and very rarely do we need to, do a more aggressive approach with the canal wall down type of procedure.
Yes.
Yeah.
Thank
Yeah,
you.
I recently had this. I never seem to get these great little ones like this. The ones that I seem to get, the glomus fills the entire middle ear. And I recently saw a general surgeon from Texas who came all the way up to see me because his daughter also works in a department adjacent to mine. And he had a glomus tumor that filled the entire middle ear, and it actually had breached through the drum. It was out to the bony cartilaginous junction, and it had extended into his mastoid antrum. And this is a physician who had sort of neglected it. So I took him to the OR, and I actually had to do this in 2 stages, largely because he was in his early 70s. And as you can imagine, I lost almost probably 600 cc's of blood by just the resection, bleeding, back and forth. And I debulked it all the way down. I had to open the mastoid. I had to do a mastoidectomy for the antral side, debulk it all the way down into the middle ear. And then I had to leave a little bit over the IS joint and the facial nerve, because at that point he'd lost quite a bit of blood. And then I brought him back, and I resected in the second pass, repaired the drum, got it completely cleaned out. It had eroded part of his ear bones, his lateral chain, and I put a PORP in, and he did great. But it was one of these where the other thing to think about too is you can stage these a little bit, so kind of let it almost involute a little bit. And what I found was it was such a cleaner second look, that was so much better to work over the facial and the IS joint area, because that already debulked like 80% of it.
Did
So
did you embolize before?
no, I did not. No embolization. Not for that. I didn't think, again, for glomus tympanicum, I really don't think I would embolize those. I think the risks would outweigh the benefits there, honestly. And anecdotally, whenever I've done glomus jugularis and larger ones, I honestly haven't really felt when you're in the OR, you don't really feel like the embolization really was that, I don't know, that effective. I'm sure it is, but I don't know. I'm very, very conservative about embolization. I just worry about the risks there. Yeah.
I've been fortunate in my career to not be sued very often, but I think one of the 2 cases I can think of was a patient who we did a preoperative embolization for a glomus jugulare tumor that had a stroke, and I was sued for that. We got off, but it was unfortunate, very unfortunate case. One other thing I'll mention, there are sometimes with these tumors, with the bipolar cautery, you can put it on a relatively low current and keep the tip spread and shrink the thing down by just gently cauterizing the surface of it. I've seen that attempted with lasers also. Sometimes you can use an argon laser or something and put it on a defocused beam and have them contract. Of course, if you get into them, they bleed. It's no different than just surgically excising it. And I'm not sure that it's the end-all be-all technique, but I do think sometimes it helps get a little more exposure if you can lightly bipolar the surface of it and try to contract it before wind up taking the vascular pedicle.
Yeah, that's a good point, Brad. On the larger ones, that's what I do exactly is you bipolar, it shrinks. You can cut with like a little micro scissor down to the fresh tissue where it's bleeding, put a little tamponade, like a little, thrombin or adrenaline, and then bipole again. It's just a very piecemeal operation. You have to be very patient with these things. They bleed a lot. And you can't just, you got to go very slowly because you can't just be blindly digging and working through a kind of a bloody pool. So you have to be very, very patient with these cases. Not like this one. This one would be nice. I presume this one would be pretty like a single scoop and then deal with the pedicle and it'd be nice. But like I said, I've never gotten this one like this, a chip shot, so to speak.
Yeah, we take these out here in Boston and then send the tough ones to Michigan.
Oh, that's great. Yeah, thanks a lot for that. So you take this thing out, and then this is what the pathologist shows you. They're like, "Oh, hey, all right, guys. So what do you see? Can somebody describe this pathology, or give me some? Is this kind of what you would expect to see based on the clinical presentation, maybe the gross anatomic findings?" Oh, there's lots of silence over there.
Not
So I
sure.
think they
That's
classify logically into cellular and vascular. Or
Okay.
some,
Are there specific kind of are there some buzzwords that you might be thinking about describing some of this histology that is specific to what you thought the tumor was?
mm,
I don't know, so must be rules. No.
Oh, putting you guys on the spot here. You got to make sure you review your pathology, right?
Yes, bro.
Do you guys spend time with the pathologists ever? Do you go down with tumors and ever go hang out with the pathologist at the microscopes a little bit?
no, not really, no.
Not so much. So have you heard of islands of Zabalan? Does that ring a bell? Zabalan? Is that ringing a bell at all?
Yes, bro.
This is kind of a classic finding here. So some of these stains, these H&E stains, they'll get these they call these sustentacular cells, and they'll take up, sometimes they'll call these non-chromaffin granulomas, and it has a lot to do with the stains, right? So, but they get this characteristic, these islands or these nests of cells. And sometimes I think obviously it was named after, Zabalan, I believe. So, but these are kind of classic findings with glomus or neuroendocrine tumors. Okay. So I think it's important whenever you're looking at tumor types, things like this, you want to make sure you look at your histology, make sure it's almost like looking at films on your own. Make sure you feel comfortable with maybe some of the basics. And again, I'm not saying pathology level analysis of mitotic features and, stroma versus, cellular components, ratios, things like this. But it's really important to look at some of these things. Just, and I don't know, do they ever do that to you guys on a board exam? Say, oh, hey, so you take this thing out and here's the pathology. I'm not sure if they do that. I know they at least did that. They've done that here on some of our board exams.
Not
No.
not certain.
Okay. All right. Okay. Just a gentle reminder then. How's that?
Are they the primary cells called chief cells? I'm
Chief
trying
cells.
Chief
Exactly
cell?
right.
Yeah, bit of
Yeah.
a
And then
large-
supporting sustentacular cells. Yeah, exactly right. Look at that. Nice, Dr. Welling. Very good.
They're kind of foamy, but large
Uh-huh.
nuclei, and
Yep.
it's quite a distinctive pattern. I mean, it looks different than
These-
others. Yeah,
Exactly. And then usually there's some surrounded by some supporting sustentacular cells. Exactly right. Yeah.
so those are the key buzzwords: Zellballen, sustentacular cells, and chief cells.
Hmm.
And
Yeah.
usually you see some blood vessels going through there too, right?
Hmm. Yeah. Usually there's like these here. See these big blood vessels? You can actually see a lot of these scattered throughout. That's why these things are so vascularized. And if you guys have ever seen one of these operated on, they're extremely bloody tumors. They're challenging to manage surgically. Yeah. Okay. All right. So I know we have about 15 minutes, but so let's say this patient comes in, they go away for a long time. You've cured them. They're doing great. Over time, somebody you're getting a call from the ER one day saying, several years later, the patient's got a headache, the chronic headache. They came in with a headache and they did a CAT scan and they said, we're finding something on the scan and we want you to comment on it, see what's going on. Okay. So they give you this. And first of all, so Peter, maybe I'll have you can punt this to one of your colleagues first if you'd like. Can somebody describe this scan to me and tell me what you're looking at? And is there anything abnormal about the scan? Are there any features of this scan that raise suspicion?
Carotid canal.
So either one, go ahead. Whoever would like to start. I know it's only one cut through this, so it's limited, but you can tell me, is it a sagittal, a coronal, an axial view? Is this an MRI? Is this a PET scan? What level are we at? What are you seeing? Is this a non-contrasted scan? Is there contrast in it? Anybody? Otherwise, I have to punt it up to Dr. Welling.
It's an axial scan.
Okay. Of what? Is this an MRI, a PET?
So it looks like a CT scan.
Okay.
And it's at the level of the secretory canal. And at that level, in terms of pathology, what you can clearly, like the most distinctive pathological feature you can see is that there's obvious widening of the carotid canal. And if this was a patient who previously had a paraganglioma or a Glomus tumor, then I would think that this would be a recurrence in the jugular bulb or a carotid body tumor would be.
Okay. Do your colleagues agree with that? Do you guys, Peter, do you guys agree?
Well, so from beyond the carotid, I think we have a lesion which seems to be eroding into the mastoid, the whole of the middle, the ear seems to be involved somewhat. So there's erosion of the carotid, the walls of the carotid, as well as the mastoid, the petrous apex. All of it is involved to some extent with the bony erosion and a soft tissue density, which seems to be isodense with the brain. So it's a non-contrasted scan, but the lesion seems to be as extensive as going into the mastoid, the carotid, as the petrous apex, all of it involved.
Okay. Okay. So you're at the same level approximately as the left side, correct?
Yes.
Right. So are you medial or lateral to the mastoid there? Is this, and is that, would you describe that lesion there as erosive, or could you say it's expansile?
Okay. Okay.
And so 2 questions. One is, are you medial or are you lateral to the otic capsule? Because you mentioned it involves the mastoid. Is the mastoid at that level right there where that widening is? Now compare it to the intact non-involved side.
You medial to it, so it's more in the petrous apex.
It's more petrous apex, right? That's right. So look at that, right? So you're not involving the mastoid at all, right? Okay. So let's talk about some of the features on the left side. What are you seeing on the left side? That's the non-involved side. What level of that do you see? Now, again, it's not perfectly, you said that this is an axial view. You're absolutely right. But you're not perfectly, symmetric across. Obviously, there's subtle variation, right? In the slope there. But on the left side, what are you seeing? Describe some of the features you see on the left side.
The petrous apex,
Mm-hmm.
carotid,
It's a pneumatized.
pneumatized petrous apex.
That's right. That's right.
You see the carotid canal.
Mm-hmm.
Yes, the eustachian tube is there, the cochlea.
Yeah.
Mm-hmm. What else do you see? What else? And just name some other structures you're looking at.
The vestibule.
This internal meatus.
Okay.
Yeah,
Internal acoustic meatus,
sort of.
some part of it.
You're seeing the IAC, right? Internal auditory canal. Mm-hmm. What are those two white dots that you're seeing just lateral to the vestibule there?
Ossicles.
Ossicles. What specifically are they? What's the one that's anterior and the one that's posterior?
Incus is
Yes, Incus stages, it must be Incus and Incus should be into.
On another cut. So have you guys heard this kind of like the ice cream on the cone?
Yeah.
Right. So that's the malleus, usually the malleus head anteriorly, and it's kind of near the body of the incus, right? Probably not seeing the stapes there, the ius joint. You're getting close because you can probably see part of the oval window there, right? Yeah. So if you compare that anatomy to the right side, you're kind of at a similar level. You're close. So you just said this earlier. This lesion is involving what? The petrous apex, right? Is it actually a carotid lesion? What tells you that's not likely a carotid lesion? You see the carotid artery on the left, right? You mentioned maybe it was a carotid tumor, or why do you think it's probably not that? What's dividing the petrous apex there from the carotid artery? What's the white stripe? Is there a white stripe there on that? What is this? What's white on CT?
Oh,
Bone, right? So this is likely you're kind of above that area, but this is likely where the carotid would be. So this is not likely a carotid lesion. This is an isolated, and I would say, is this smooth or is this moth-eaten and eroded? Is it smooth or is it moth-eaten and eroded?
Exactly where you are, looks like it's moth eaten area where your cursor was.
Do you think it's moth-eaten or do you think it's more smooth and expansile?
I'd say it's both. There are places where it's smooth and expansile, and there are
Okay.
places where it's gone, so it's moth-eaten.
Okay.
I don't think it's easy to characterize, but the fact that there is what looks like an expanding circumference of bone makes you think it's primarily expansile rather than erosive, because they're
That's
not
right.
totally eaten up.
Correct. There's still elements where see how smooth it is here. These edges are not jagged. I mean, again, back here a bit, but it's pretty smooth here, right? So you're in the petrous apex, right? So what's some of the most common pathology that you might find in someone's petrous apex? And why? What are some of the things that would immediately jump out at you? Petrous apex. When you think petrous apex, you might be thinking some things probably immediately would pop in your mind about some common pathology that might occur at that level of the skull.
Granulomas.
Anything else? Can you name two or three?
Vestibular schwannoma.
The schwannoma and the petrous apex kind of pretty that less likely, but okay.
Tumors.
What's in the petrous apex? If it's not got air, if it's not completely aerated, what's typically kind of the bone in this area?
We need to have name tags so we know who to call on.
Mhm. So the bone in this area, is it soft? Does it have medullary bone? Is it marrow-like? Does it have fat? Does it have blood? Does it have air? Does it have what's that?
So there's a proportion of people whose petrous apices are pneumatized, but it's
Sure.
definitely the minority, I think. Majority is modality bone, I think.
Yeah, right. So what, knowing that, what else is in there that this could be? So think about your differential. You already talked about a cholesterol granuloma, which what is a cholesterol granuloma? What is that?
You said it. What is it?
So what we'll do, guys, since we have a few minutes, we'll develop our list of differentials, and when we come back next week, you guys will tell me everything you need to know about the petrous apex. Right? Yeah. So let's think about a differential. Let's get like at least five things on the differential. You said cholesterol granuloma. What else?
Tumors,
Okay, what kind of tumor?
benign like osteomas, other.
Okay, would an osteoma be a soft tissue like this? Osteoma is what?
Bone, to be bony.
Yeah, maybe not, but yeah, okay. So we said cholesterol granuloma, you said a tumor. What other kind of what benign tumors could be in that area?
If it were congenital, what would you think?
We got some reading to do, I think.
Yes, for cholesterol.
Peter got it. Cholesteatoma. That's what I was thinking.
Cholesteatoma, right? So, or epidermoid cyst, cholesteatoma, sure, absolutely. What else? I said that there's blood and fat in there. What does that help you describe a tumor?
Yes, blood
What do you call a fatty tumor?
Lipoma.
A lipoma. Could be a lipoma, right? Yeah. What is the most common malignancy? I'm sorry?
Pyogenic granuloma, do you get them then? Is it vascular? Pyogenic granulomas, do you get them then?
A granuloma? I suppose, yeah. But that's that's sort of like your cholesterol granuloma. What's the most common malignancy that would be in this area?
Lymphoma.
I would say that's the most common. You can get lymphomas to the skull base. There's no question, right? You can get lymphoma can spread to the ICs and look like schwannomas, melanomas can spread there as well. What is it about the petrous apex? What the petrous apex abuts against what other structure? The petrous apices meet what in the midline?
So meningioma is
Possibly, but what do the petrous apices meet in the midline? If you're looking at the skull, you have a skull with the calvarium off, and you look at the petrous apex, they come up. What are they meeting in the middle? I'll give you a hint. The brainstem lives on this thing. The basilar artery lives on this thing. It's like a children's slide. If you were sitting on it, you would slide right down into the foramen magnum. What is that called?
Clivus.
The clivus. Okay. What lives between the petrous apex and the clivus?
But to it.
No. Do those two bones just meet bone to bone, or what's usually between two bones? Think about your knee. What's between your femur and your tibial plateau?
Oh, chondrosarcoma.
Cartilage, the petroclival synchondrosis, right? Cartilage. What cancers can arise from cartilage? Chondrosarcoma. Yeah, good. Okay. All right, we're gonna leave it there. You guys have some reading to do.
Yes, Prof.
So next week, we're gonna still work on this tumor a little bit, okay?
Yes,
And we're gonna think about, so look at that. What would you want to do next? You don't have to answer right now, but how would you, what could things could be, could you do to better get an idea about what that is? Sound good? Brad, any thoughts? Not necessarily on that, but we don't want to give it away yet.
Well, no, I know, I'm restraining myself. Saying, you know, we nicknamed the fatty tumor a Harbaugh, but we're not gonna say that.
Oh, man.
That's the name of the coach of this football team.
So, yeah, so really important, guys. I think the take home this is always look at your own films. Always, if you can, look at pathology, you know. It just, I think it, you know, it always just enhances your understanding of what's going on. It's really important to be in the know there, right? Because, you know, radiologists and pathologists make mistakes, right? And I'm not saying that we're all perfect, but I'm saying it's always good to be up on those things. So you're looking at that kind of stuff to make sure you feel comfortable with what you're looking at, especially not so much the pathology, because you're not going to be doing that all the time. But I always tell the residents here, I said, you got to look at your own films. The worst thing that they could say to somebody like is like, oh, I said, what was the film show? And they go, well, I'm waiting on the radiology report. Like, oh, that's like, that's like one of the worst things they could say. They could call me a bad name. I'd rather they do that first than say, I'm waiting for the radiology report. Because it tells me that they're waiting for someone else to tell them the information about what they should really know, right? So really get in a habit of looking at your own films and spend time, right? And if you've got disease on one side, we'll look at the other side and really compare the normal versus, but you have to have a really good command of the normal anatomy to really discern what the pathology is. Does that make sense? Or what's been the change away from the normal? How should this normally look? And think about those terms like expansile. Is it erosive? Is it these types of things? Because that really can dictate a lot of what's going on, because in many of these circumstances, we don't have the luxury of a quick biopsy in the clinic, right? A lot of these deep-seated areas, they are out of touch. We can't get to those areas. They're not accessible, right? So we rely on radiographic characteristics oftentimes to make diagnoses, right? But there's a lot of things that are very characteristic that you can sort of at least narrow down the differential that can help you. Make sense?
Yes, Prof.
One other last thought before you leave. In terms of these glomus tympanicum tumors, one of the things that I think is very helpful if you get in the temporal bone lab and do an extended facial recess approach, I think it's interesting to follow along and go ahead and remove the chorda tympani nerve after you've done the facial recess approach, remove the chorda tympani and follow along under the annulus and see how far inferiorly you can get, what kind of exposure you can get by extending the facial recess. The tympanic bone is surprisingly thick in most patients in that area, and it takes quite a lot of work, but you can get quite a lot of exposure in the hypotympanum by extending the facial recess. And so it's a good exercise if you get in the temporal bone lab to think, okay, I've got a large glomus tympanicum here. How am I going to get around the whole thing and see what kind of exposure you can get by just really following the facial nerve all the way down, taking the chorda tympani nerve and taking out the tympanic bone. It's an approach we use when we're taking out the lateral temporal bone for a malignant tumor, but it's not done very often, and I think it's a good exercise when you have that opportunity.
Yes, please.
All right, guys. Great. Thanks a lot. Have a great weekend. We'll see you next week. Thanks, Brad.
See ya.
Bye, guys. Take care.
Wow.